Anish Chopra is in the house, so we want to turn the floor over to him as soon as we can. All right. Just a few words. I think many of you know Anish Chopra, who is the U.S. government's first Chief Technology Officer. In that role, he reports to our President Obama. Anish has brought such energy, enthusiasm, and let's do it kind of a spirit to the Chief Technology Officer's role. It's going to be a hard one for the second one to ever fill, but we hope he stays with us for a long time. So Anish was started with his public service role with the state of Virginia, my state, so I'm very pleased that he started there. He did a lot to really get Virginia on the right track. And he was also selected as one of the top 25 doers, dreamers, and drivers in 2008. So let's welcome Anish to the podium and thank his staff and everyone associated for making this time available for us at Continua. And I think he's already put together 2 or 3 deals. He's only been here 10 minutes. Yes. So come on up, Anish.
Hey, look, we're with Guruji over here, Dr. Reddy. He's an inspiring man, and I would tell you, any chance to be with him, I will do whatever I can to be a part of that. So that's actually why I'm here today, because I saw he was on the schedule. In all seriousness, I'm excited about the potential for telemedicine and healthcare IT more generally to make a big impact, not just in the U.S., but around the world. I will share with you my passion and enthusiasm for this in my remarks, but I want to just, as a setting of the stage, there's policy and vision, and then there's action on the ground. And I think the big news of 2011, as we wrap up the year, is that the potential for health IT and telemedicine is now shifting into results. And so we're moving from sort of prototyping and piloting to validating and soon scaling. And that's the exciting, yeah, get some love for that. We're doing that. We're doing that. So I'm going to do my best to sort of frame this in the U.S. context as much as I can to talk globally about the opportunities. And if I may, I'll say a few words about U.S.-India collaboration in this space, because it is, although this is an international conference, I might just say a few words about that. I want to just begin with, just philosophically, how does the U.S. think about these issues? On the president's first full day in office, that is the U.S. president, Barack Obama, he memorialized a vision of bottom-up change when he issued a directive on open government. And that vision has now scaled around the world. We've been implementing open government in Washington, and other countries have been as well. Just in September, the president gathered with 40 heads of state to launch an international charter for open government, built on the principles that we should listen more to the citizenry, find new ways for them to participate in their government. We should be more transparent in the actions that we take so people can hold us accountable. And we should be more collaborative in the execution of policy. The collaboration pillar, by the way, is where I see tremendous potential in the telemedicine domain. We also, as part of that effort, published for the United States a National Action Plan for Open Government, which emphasizes our use of open health data to spur breakthroughs, and you'll hear me talk about that more in a moment. But this is a philosophy, and the reason why I'm in India today is Sam Petroda and I co-chair the U.S.-India Open Government Dialogue, and we announced that together, the United States and India will jointly develop a new open source software platform that we're calling the Open Government Platform, which takes the U.S. government's data.gov platform and India's document publications activity and will make freely available for the world in March of 2012 a platform that will facilitate open government, which I think is a great opportunity. So we're having fun talking about that. Let me just set the stage for how we think about telemedicine as part of the overall strategy for, at least in the US, American innovation. Now, I put these graphs up not for you to read all of them because the words are too small, but I want to just share with you President Obama's vision for innovation has 3 roles for government. As investor, we are predominantly focused on the building blocks of innovation, what you would call infrastructure, and from our point of view, wireless is an absolute infrastructure need for the 21st century economy. So we've put forward a national wireless initiative that is absolutely focused on ensuring that the next wave of economic growth of the internet in the wireless arena will take place. We want U.S. leadership in this. Of course, we think there's global potential. The second area we see for the government is to set rules of the road. Now, in the internet, as an open platform, how does one balance true policy initiatives around privacy protections, security, intellectual property enforcement, in an environment where you have a largely global open platform for economic growth or any one of a number of social empowerment applications? So we've put forward a strategy of internet policy principles that we've taken to the OECD, and 34 countries have endorsed this strategy of multi-stakeholder, bottom-up collaboration. In part, why I'm excited about Continua's announcement is that we're relying more heavily on standards bodies who voluntarily convene to establish standards to solve these challenges. You'll hear me talk about more of that in a minute. And last but certainly not least, we think we have forgotten the most important role of government, which is to convene and to lead, not necessarily write rules or invest. Convene and lead. We call this the role of government as impatient convener. And it is in this role I can cut as many deals as I want because there's no procurement, there's no Congress. It's just good people coming together to say, hey, why can't we do this? And that's a spirit of open government, which is what I talked about a few moments ago with the Open Government Charter. There are opportunities in my remarks today that you can work on without ever having to email me, call me, asking for permission, getting my blessing, nothing of the sort. The resources that we're making available are there for you to deliver breakthrough solutions. And the great news about the global innovation ecosystem is great ideas that are prototyped start to get evidence and they start to scale. And what we wouldn't have imagined 2 years, 3 years from now will be a de facto standard because it's taken the world by storm. We want to create the conditions for that to happen. Now, I mentioned a few minutes ago about examples of rules of the road that speak to this voluntary, agile model of cooperation. I want to share with you one example of this model in healthcare. In a room like this, although without the fancy white cloth on the chairs, this is very fancy. Is this you doing, Dr. Reddy? Is this how you roll in the Apollo community? We heard testimony. I was chairing a hearing on implementation for the President's Health IT initiative. And we purposefully wanted to hear from doctors, hospitals on the ground, not just the lobbyists who come to Washington that, have the fancy suits and the fancy shoes and they tell us, what they think we should be doing. We wanted to hear from real people. And what we heard was a doctor testified. Now, it wasn't in his prepared testimony. We had a bit of a conversation. And he says, I want to share with you a problem. I have a patient that's moving from my primary care practice in Virginia to a primary care practice in Arizona. And they asked me, can I email the medical records to the new doctor in Arizona? And the software that the doctors both had was the exact same software, but neither of their packages had an email button. So his IT people, with patient permission, exported the record, attached it to regular email, sent it over the internet, imported the file, and it worked. Now, while he's sharing this story, in most Washington meetings, you don't have technicians, you have lawyers. And so the lawyers in the room had a heart attack. You can't email that record. It violates HIPAA, privacy, security. That's terrible. Someone could divert that email and publish that patient's medical record, and that would be a terrible thing. And the doctor acknowledged that it would be a terrible thing, and he said, all the billions of dollars you're spending, when can I just email my patient's record? Dr. Reddy? Right? Am I right? So he was correct. We did not have a bottom-up voluntary standard for emailing each other. Boy, we had fancy rules for how you would interconnect data, query response, signing a DRSA privacy agreement, connecting up to this massive IT infrastructure, plugging it in and testing the model. And we've been spending $1 billion on that for 10 years, but no one's using it for email. So we asked the question, if this is such a problem, why can't the community solve it on its own? So in the spirit of government as impatient convener, we asked all of the industry, about 80 private companies, in 90 days, can you all agree on a specification for safe, secure email? And in the beginning, it was scary because some believed in a RESTful approach. Some wanted to have it on SOAP, leveraging the IHE framework. Others were interested in SMTP because that's the backbone of email. And it was almost like a Worldwide Wrestling Federation battle royale because techies kind of make big deals out of nothing. And we said, just figure it out in 90 days. We're not solving, world hunger. Billions of dollars are not going to change hands because of this action. We're just allowing email to work. And it turns out that all you want to do is authenticate the sender, authenticate the receiver, and encrypt the message in between. Okay, we're not inventing a new form of physics. And thankfully, in a very open platform way, the directproject.org was formed, and they agreed on an SMTP version in 90 days. 90 days after that, voluntary teams built reference implementations in Java and in .NET. I must add, by the way, in the spirit of Indian technology professionals, the Microsoft Health team shared with me a little story. So it turns out that we could see who was checking the code out and checking improvements in, because that's all logged on the directproject.org website. And there was a lot of activity on weekends, which obviously meant professionals were volunteering their time. No one got paid. We didn't pay anybody. And the Microsoft guys were teasing me. They're like, oh yeah, it was all our Indian engineers, a lot of US-born or US living Indian Americans who were volunteering for this effort. But because it's an open platform, anybody could have checked code out, contributed code back in. So 90 days later, they had reference implementations. And not even 90 days after that, a startup in Minnesota, not startup, but an early stage company, had no lobbyist, has no government contracts, had no procurement expertise, saw the code and decided to commercialize it. They charged a one-time setup fee of $495 to a local hospital to do unlimited emails of children immunizations data to the state health department, which replaced a $30,000 point-to-point IT solution that took them months to design. This was built in 2 hours with no implementation cost, and it was by a company that I hadn't heard of called VisionShare. But that's an open platform, and they proved that it works. So 90 days after that, which is 1 year to the day we launched this, we launched it in March of 2010, we had 70 vendors of health IT products in the US pledged to endorse the direct specification, accounting for 90% of the market share in the US. And this direct specification is now scaling all over the United States. I might add, by the way, everyone in this room should have a direct email client certified, right? You should all just do it. It's directproject.org, play, join the family. I'm going to ask Dr. Reddy to join the family. Will you say yes to join the family? Are you in? Dr. Reddy is in the Direct Project. I'm going to add his name. Give him some love. So you're going to see these applications. And oh, by the way, it's funny. I'm asking, what's the price point? So one of the vendors is offering unlimited, safe, secure email to every primary care doctor in America, $12 a month. It's pretty cheap. It's a commercial market. Maybe someone's going to offer it for less. Someone's going to offer it for more and not value-added services. God bless you. That's an opportunity. So this is an example. By the way, this We have not even issued a regulation on this yet. We haven't even proposed the regulation. That will come out in the second stage of meaningful use. But it'll be an unnecessary act because it'll be wide-scale, it'll be adopted anyway because it's happening from the bottom up. That's the philosophy. So now I want to talk about why I believe there's never been a better time to be an innovator in healthcare. And the rest of my remarks will provide for you specific and tangible activities that are not memos or white papers, but they are code and opportunities now that are at the intersection of information liberation and incentives that we're adopting in the US to create the market conditions for the innovative applications, many of whom I believe will be powered by mobile broadband. Now, let me go through each of these in order. The most obvious thing we can do is eat our own dog food. If we believe in openness as a matter of policy, then we should ensure that every data set we have in healthcare is made freely available for entrepreneurs and innovators around the world. So, under the leadership of my dear friend Todd Park, the Chief Technology Officer of HHS, who, by the way, in his private life had co-founded Athena Health, and I might add, I believe it's at Health Point here in Punjab? Yeah, Health Point, right? Health Point. So he even invested in a social venture here in India. So he gets this. Todd has been on a crusade to open up government data in healthcare and launched health.data.gov. And look at the growing catalog of data that we've made available. Data on public health statistics, on provider quality, on individual health information via our Blue Button service, product information, and research data. Everything we have access to, we are publishing. And I'll just give you an example, Dr. Reddy, because you're sitting here looking all handsome. We decided to open up the National Library of Medicine, the world's largest repository for medical information. And we published a set of programming interfaces. And we ran a contest, the Show Off Your Apps contest. And we had the winners just about a week and a half ago, November 2nd. And the applications are so brilliant. One of them is called Knowledge, KNALIJ.com. And what they do is they visualize all the principal investigators who've written articles in PubMed. PubMed is our open catalog of articles on peer-reviewed literature for advancements in healthcare. Literally, if you go to visit Knowledge, you can visualize all of the lead authors for all of these papers and how they interrelate with each other. You can see that this person is highly published, and second and third author, there are these hubs and spokes that link. You could start to see global networks. Who are the people that are working with each other? Not everything has to be top down. You don't have to call me to say that you'd like to see a collaboration between a researcher in India and a researcher in the US. Thanks to applications like Knowledge that are freely available, thanks to our Open Data Initiative, you can see on the ground who's actually publishing high-quality research in areas that are relevant for you. Right now, you can find all the telemedicine researchers right now. You should build an application on our programming interface at PubMed to talk about global interconnected networks right now so that investors can find where these networks are forming and have greater confidence that they're going to result in something that they can commercialize. Right? That information is publicly available. It hasn't been brought to our attention. I also want to share with you one of my favorite applications is here on the right, iTriage. This is a startup in Colorado. I was in Colorado this week. I met the CEO of this company. And just to give you an example of a new kind of government, normally when I take a meeting, people ask, there's two things people come to me for. They want money, thinking that I have money. Have you seen my wallet? I got nothing in my wallet. I got nothing. They think they're going to come for money. Or two, they want a change in law. Okay. Those are important things that you can petition your government for, and I welcome those conversations. But this CEO actually didn't know why he was coming to see me. He didn't really want anything. He was doing fine. But he wanted to tell his story. He said, let me tell you what I'm doing. I'm creating a mobile app that would allow individuals to, with some preliminary diagnostic information, triage them to the right healthcare provider. Very simple app. And I'm not here to say, like a Guruji, great, I love your work, I bless you. No, it's his company, he can do what he wants, go for it. But I flipped the model around on him. I said, we have a database of all of the federally qualified health centers that offer lower cost medical care. Would you do me a favor and ingest that database so that when you're offering a triage service, you could actually help connect people to a lower cost service? He says, hey, I hadn't thought about that. Happy to do so. Dr. Reddy, I was with him last week. About 15 months he's been live. He's generated 76,000 referrals to federally qualified health centers. No cost to the American taxpayer, and just a judgment on his part to ingest that data set and put it to use. He's so inspired. He cares about substance abuse and mental health. He's now working with SAMHSA, our Substance Abuse and Mental Health Division, to get even more data to help people on suicide prevention and other very important policy issues so that his platform can provide more than just the triage service that he initially thought he would do. He now sees it as mission critical to his product to ingest that open government data. And by the way, he's so successful, Aetna just acquired him. So he's on the move. And again, that opens up an opportunity to take advantage of these movements of open data. So it's not just the liberation of data in government websites. We are increasingly nudging this information out of the private sector as well. So I want to introduce you to another innovator in our government, Dr. Peter Levin. He's the CTO of the VA, which is our Veterans Administration, and he had to answer a presidential challenge. We believe in the tech community we can get things done in 90 days. Things don't have to take 2 years of meetings and triplicate and meetings and opinions. And let's have a memo, and we'll then sign the memo, and then next year we'll come back to the meeting and bless the fact that we previously signed a memo. That's not how we operate. We want to get things done. So the president in October of 2010 said to the VA, I challenge you that this fall you should provide all veterans the ability to download their own health care information via a simple blue button. So in 90 days, Peter and his crack team, in collaboration with the Markle Foundation in a very open way, designed a very simple text file that a veteran can download on their personal health record called My Healthy Vet. It started off small because these things are, we're not solving world hunger overnight. It was, we have your medications list. You can download a copy of your medications list. 6 months later, we've added lab results. Soon we'll have images. It gets better over time. Dr. Reddy, guess how many Americans have downloaded their blue button? We are now exceeding 500,000 Americans have downloaded their healthcare data via blue button. It started off in the VA, it's now available in Medicare, and it's available for the active duty military. But guess what? It's not limited to the government. In September, Health Secretary Kathleen Sebelius gathered the private sector, and we secured pledges from Aetna, United, Walgreens, startups like Patients Like Me. More recently, we've got commitments from Athena Health, and we just got one from McKesson, all pledging to allow their customers to download their own data via the simple blue button. Why? Because while we're trying to solve global data sharing networks with security and privacy, the one thing the whole world can agree on is that patients are entitled to their own data. There's no privacy rule that stops you from giving your own data to the person. So our point of view was, let the patients have their data. Now, a lot of cynical people said, our patients aren't very technically savvy. What are they going to do with that file? Shame on you for asking that question. We live in an innovation culture. Entrepreneurs will come knocking on their doors, and they'll say, Dr. Reddy, if you have a blue button, allow me to upload it for you, and I'll give you all this value-added service. So now there are companies who are building a solution telling people, if you've downloaded your data, upload it with me and we'll make your life better. We have examples of this. One of the most powerful consumer financial services is a company called Mint.com in the US. Helps people manage their bank accounts and their financials, and it gives them advice. Now there's a market opportunity for someone to invent the Mint.com of healthcare. Because now that 500,000 Americans have downloaded their data and millions more have pledged to make it available, there will be a new marketplace of delivering valuable services on the Blue Button format. Dr. Reddy, will you allow a patient in the Reddy family to download their own data? You will. See, this is the benefit of being on stage, is you have to say yes now. He's got to say yes. So we'll add Apollo hospitals to the growing family that'll support the Blue Button specification. You have 20 million on your personal health record? You offer, this is, oh, he's volunteering, Ganapati. So we'll get you to support the Blue Button. Imagine if in 30 days or 60 days or 90 days, you offered the Blue Button, the first international deployment of Blue Button. The race is on, by the way. Who's going to beat Apollo to the punch? All of the details and specifications are available at bluebuttondata.org, a site that's supported by the Robert Wood Johnson Foundation. And we made the design so technically simple that you should be able to do this. If the VA can do it in 90 days, I think everybody can do it. It's just a judgment call. It's a judgment call. Actually, it will be a fun test for the Continua Alliance that's launched here today in India to see who's the first Indian partner. And we'll tweet about that when we find out. And the race will be on. The race is going to be on, the first to support Blue Button. And by the way, this is also a business opportunity. Who's going to create the Blue Button import feature? So that as soon as someone downloads it, what do they do with it? You'll say, upload it with us. And we'll wrap that value-added services. So that a year from now, when you gather here, the showcase outside will have 10 applications powered by that Blue Button upload that showcase all the great things people can do. This is the spirit of open data. Now to incentives. It's no secret in the US that we believe strongly that we should drive the adoption of electronic health records. But we have a slightly different formula than the top-down formula that you saw other parts of the world take. We have designed a bottom-up, standards-driven model. What that means is individual hospitals and doctors make the choice as to the software platform that's right for them. There is no one procurement with one product that the whole country has to adopt. We want massive competition. Prices are falling. Choice is growing. We went from 100 certified electronic health record products to over 1,000 in the last 2 years. Why? Because we made some very specific judgments. The most important were this. Number one, we defined what it was that we thought a healthcare provider powered by IT should be. What is a meaningful user of healthcare IT? That emphasized quality and value over documentation and billing. Today, IT is phenomenal at billing and scheduling because those are two things where you can make money. But improving quality and outcomes, we're still in the early days. So we said, again, allowing people to track their blood pressure. Dr. Reddy, did you know that our systems in the US didn't come out of the box ready to track blood pressure? You have to ask for that as a requirement. Our systems in the US didn't allow individuals to download their own healthcare data? That wasn't a requirement. Kaiser spent $3 billion on the most advanced healthcare IT system in the world. Yet if you asked Kaiser, how would you provide patients an electronic copy of their data? Oops. That wasn't in the IT requirements document. In some cases, they put it in a thumb drive. Others, you have to log into their MyChart. So now we're putting these requirements. Oh, and by the way, Dr. Reddy, nobody can do population management. Show me the patients that have not had their blood pressure checked in the last 30 days or whatever. Right? That wasn't kind of the kind of data analytics work that I'm describing, wasn't part of the engineering for the initial batch of electronic health record systems. So you start to define these requirements, what we call our meaningful use requirements, and now you've given people a target. Engineers are great when they see a target. Now I know the requirements. I'm going to innovate. The second thing we did was we opened up the idea of modular certification. What we wanted to do is to say that in order to qualify for the incentive payments that we're offering providers, doctors and hospitals, they had to adopt certified systems. So we didn't want to have a top-down single solution. We wanted to have a set of standards that would be ever-changing. That is, we believe to escalate the standards over the next 5 years. So we've got the first foundation ready. We're about to announce the second, and then we'll have a third round, each one to be better on interoperability and security and privacy and so forth. And these certified products, we said, look, instead of certifying on every one of these requirements, maybe you could be expert in one. And we would allow those modules to be reimbursable. So that now there is a vibrant third-party apps ecosystem. I think I have a picture of Dr. Ho. I might. I'll check to see if I have a Dr. Ho picture. If I do, I'll come back to that in a minute. Why is all of this relevant? Because the data is overwhelming. In Cleveland, they did a survey of 27,000 patients, Dr. Reddy, on the issue of diabetes care. Now, Anand is in the front row, Dr. Anand Iyer. He will tell you about diabetes care. Every third-year medical student in every medical school in the world knows that if you have a patient who's diabetic, you should check their foot, check their eyes. There's some basic things you're supposed to do. Those 27,000 patients that had doctors on paper records only got those things done 7% of the time. 7% of the time. Electronic records, they were better, but not perfect, 51% of the time. And if you drill down in the electronic category, those that had alerts and reminders were even higher still. But I tell you, if only 7% of the time a diabetic patient is getting the recommended processes that a third-year med student would offer, that's a shame. Is that a shame, Dr. Reddy? That's a shame. Absolute shame. So, the question then is, how relevant are these processes to outcomes? They also tested whether or not the patients saw a change in their blood pressure, their smoking status, their hemoglobin A1Cs. So they started measuring the outcomes too. And only 16% of the patients in paper charts, paper records, 16% of the patients that had providers that only used paper achieved the outcomes. But 44% achieved the outcomes when it was an electronic health record, powered clinic. And again, that too got better as more features were added. Dr. Reddy, when you look at that evidence, is it any doubt that health IT achieves quality improvement in healthcare? Any doubt? No doubt, Dr. Reddy, no doubt. That's why we're seeing massive adoption. In the US, we've seen a doubling of the adoption of electronic health records in the last year and a half. And that's before a lot of our incentive money has even been spent. So here's where I want to talk about the idea of third-party apps. This is a picture of Dr. Gunston Ho, a Chinese-American who serves, or maybe Vietnamese, actually, who serves an Asian community in downtown San Francisco that is very poor. He gets paid more money to see his Medicaid patients because he struck an agreement to take on more care coordination and responsibility. With the additional reimbursement, he needed new features in his clinic to identify which patients are most at risk of additional care needs. His basic EHR did not have the kind of analytics and search features that he wanted to have. Because we believed in modular certification, he was comfortable going to a Silicon Valley startup called Apixio that has developed a Google-like search interface on top of his legacy electronic health record. Dr. Reddy, he could have waited for his vendor to build out that search feature in version 0.5 3 years from now, or he could, in interoperability, layer that by this third-party application and interconnect it so that there can be breakthroughs that are available today. This is the secret sauce. By opening up applications and allowing modular certification, we're starting to see new companies form with expertise in these specific areas. You'll see my punchline for the telemedicine community in a minute, but you can imagine if you're really good at that, and you can certify as a module, you can participate in the US program. That's our view. Now, I want to come back to the point that he got paid differently, because the second part of the incentive change is this. Dr. Reddy, in the United States, changing the way a doctor or a hospital gets paid is very complicated. Very complicated. Streams of lobbyists come knocking on our doors in Washington every year to convince Congress to make this tweak or that tweak. And the telemedicine community, God bless you, are in the same boat. When can I lobby Congress to get reimbursement for telemedicine services? That game is over in the United States. In the Affordable Care Act, health reform, the provision now exists where a new Medicare Innovation Center has the legal authority to change payment models. And if the evidence from the change in payment models increases value and lowers cost, the Secretary of Health has the authority in our executive control alone to scale that payment model across all of Medicare and Medicaid without going back to the US Congress. I no longer want to hear any whining about reimbursement rates and telemedicine not getting covered. We have a new venue for such conversations. It is now incumbent upon us to bring those products and services as part of a larger payment reform solution. What does that mean? If Dr. Ho is paid 180% of Medicaid to treat patients in a more coordinated fashion, does Dr. Ho want to do remote monitoring to make sure that his patient's heart condition or their diabetes is under control? Does Dr. Ho now have the financial incentive to make judgments to buy products and services to achieve those objectives? Does Dr. Ho need Congress to give him permission to enter into such business arrangements? No! Those providers who are part of our new payment model, pay for value, whether it be bundled payments, medical homes, ACOs, readmission work, a whole range of new solutions will come forward. And even more will come that we haven't even defined yet. The policy framework in the US is now on how we can change the payment system to deliver more valuable, a value-based healthcare system, no longer getting each one-off solution the old way. Because the products and services that win in helping the Dr. Ho's of the world keep their patients healthier, lowering costs, we see a $1 billion market in just empowering the Dr. Ho's of the world to be better at supporting care coordination, data mining, decision support tools, extending the reach of the physicians, engaging consumers in creative ways. All 5 of those, Dr. Reddy, do you see telemedicine in those 5 areas? Yes, you do. That's the path to market. The path to market is now, in the US context, serving those doctors and hospitals who raise their hand and say, I do not want any more to be paid for 6-minute office visits, that next year will be 5.5 minutes, that the next year after that will be 5 minutes. I want to be able to care for my patients. I would love to see reimbursement. I would love to make more money caring for my patients as opposed to this limited time. And I've seen the proof, Dr. Reddy. I visited a primary care clinic in St. Louis where the doctors have doubled their income while improving quality, lowering costs, and they're paying for new technologies in creative ways that I've never seen before. Because they've entered into a financial arrangement where they're rewarded for improving outcomes. I don't know the one payment formula that will scale and be the winner, but I don't have to know one formula. All I know is we have the legal authority to experiment, to test and validate, and then scale what works. This is the most important policy innovation in my humble opinion, to spur breakthroughs in telemedicine, at least in the US context. I don't know how it would work in India. Finally, we are opening up the model for how we actually provision health insurance in the United States. We are establishing new online marketplaces, Travelocity.com, Expedia.com, MeetHealthcare.com. Each of our 50 states will have an insurance marketplace powered by information technology to help individuals find the insurance products that are right for them. And I have the honor and privilege of chairing the technical standards to support how those should operate. How should patients in these insurance exchanges maintain or support their medical home, their medical data? Imagine third-party app developers extending the value of these insurance exchanges, allowing individuals to store their healthcare data on the exchange, liberating it from the insurance companies or the providers directly. Under what standards should we facilitate that kind of activity? How should brokers and third-party application developers convince folks to sign on for new insurance products? This is an exciting new world, and we will be developing the technical architecture and implementing this over the next several years in the US to build a more internet-oriented insurance marketplace for healthcare, bringing down costs, increasing choice, and adding tremendous value along the way. I've published, by the way, a technical foundation for all of this. We called it Section 1561 of the Affordable Care Act. And if you simply Google healthcare, Section 1561, Affordable Care Act, you'll find the standards. It's also available at healthit.gov. Finally, and this is where I'll end, we believe that there's never been a better time to innovate because of one truism. There is expertise in every corner of this planet, ready to be tapped to invent the solutions we will celebrate in the years to come. And it is shocking how we've failed to capture that intelligence and that capacity in the past. But I want to share with you an example from our nation's military. If you want to talk about culture change, if you did the math, the cost to build an aircraft carrier will exceed the entire budget of the Defense Department by the year 2054. If you simply plotted from 1950 on the cost of an aircraft carrier, and you just sort of drew the line, extrapolated the line, it is outrageous. The manufacturing innovation challenges in our nation's military are profound. So DARPA, the R&D wing of our nation's military, said, we will pledge to invest $1 billion over the next 5 years to find ways to cut by 80% the time to design and prototype a new vehicle. That's a bold goal, Dr. Reddy. That's not a 5% improvement, Six Sigma. That's 80%. 80%. And to prove that they're willing to try breakthrough ideas, in January of this year, they put up a contest. Anybody in the United States that has a design that meets our specifications for a combat support vehicle, you have 3 weeks. Submit your design, and may the best design win. You get a $10,000 check for the best design. This good-looking guy next to me, not Dr. Reddy, but another good-looking guy, Victor Garcia, sitting in front of his vehicle. He immigrated to the U.S. from Mexico at the age of 5. He went to community college. He did not get straight A's. He did not go to Harvard. He had a dream of being an engineer, but he had an entry-level job at a trucking company. His own company would not have known the quality of his work. Victor Garcia found out his wife was pregnant in January, and he lacked health insurance. He needed the money to have a good, healthy pregnancy for his wife. He found out about our contest in January. He decided he'd put his heart and soul into the contest. And he designed that gorgeous-looking vehicle you see at the top. And he beat out all the entries around the country. A guy who would not have been known, his talents would not have been known by his own employer, came out first, got a $10,000 check. But the story doesn't end there. The nation's military found a manufacturing facility in Arizona called Local Motors, willing to take that design and build a prototype in 6 months, not 3 years. They took the design and they produced that car that you see right here and drove it earlier than anticipated from Arizona to Pittsburgh, Pennsylvania. Why, Dr. Reddy, did they take the car to Pittsburgh, Pennsylvania? Why? For fun? They wanted to hand the keys to an important person, the President of the United States.